Good afternoon from a very wet and cold Glasgow. My name is Gordon McInnes, and I am going to talk to you about high blood pressure and its relationship to coronary artery disease and heart failure, with some comment on some of the newer drugs that we have available to treat this condition. Now, we're talking to you from Glasgow, and Glasgow is sometimes known as the city of the damned. It is said that living in Glasgow is equivalent to involuntary euthanasia. The reason that people say that is that if you look at life expectancy around the world, even in poor countries, it's currently around 57 years. And in richer countries like Scotland, where Glasgow is, it's around 80 years. Yet in parts of Glasgow, life expectancy is still only 53 years. And that's why we are sometimes known as the city of the damned. And the reason why people die early in parts of Glasgow is because of cardiovascular disease. At the time when this headline, the city of the damned, appeared, Glasgow had the highest rate of myocardial infarction in the world. We're no longer in that position, but we still have a lot of cardiovascular disease. And there's a strong link between cardiovascular disease and coronary artery disease and heart failure. So cardiovascular disease is the principal cause of mortality around the world, and blood pressure is a main risk factor. Suboptimal blood pressure is independently responsible for 10 million deaths annually, half of which are due to coronary artery disease and about a quarter due to stroke. So high blood pressure is a very, very important consideration if we wish to try and reduce cardiovascular risk. Unfortunately, there is a lot of hypertension around the world. Hypertension, by the middle of the next decade, it's estimated that more than 1.5 billion people globally will suffer from high blood pressure. And this is spread all around the world. And if you look at these figures, you see that much of the increased risk of high blood pressure will be in countries such as Latin America, in the Middle East, in South Africa, in East Asia, and in the Pacific. So the problem of high blood pressure is no longer a problem of Europe or North America, but it's a global problem with increasing risk, particularly in areas which would no longer, in the past, would not have been thought of as high-risk areas. And this, of course, is because life is changing. Most countries are becoming westernized in some way or other. There is modernization and urbanization, and these things are causing a shift in the burden of cardiovascular disease from Europe and North America to the whole of the developing world. Now, some years ago, this man, Mahatma Gandhi, was asked, what do you think about Western civilization? He was a very thoughtful man, and he pondered over this for some time, and then he said, I think it would be a very good idea. So what he was saying is that we in the West are not as clever as we think we are. We are not particularly civilized. Many of the things we do are counterproductive, particularly with regards to our cardiovascular health. So blood pressure is a big problem, and it has a very strong relationship with both stroke and coronary artery disease. This well-known slide is from the Pooling Project. It shows epidemiological data on more than 1 million individuals. And what we're looking at here is mortality in relation to blood pressure within 10 years of the individual dying. And you see that there's this continuous relationship between blood pressure and the risk of stroke at all age groups, and right across the range for both stroke and ischemic heart disease, right down to a systolic blood pressure of 115 millimeters of mercury. And probably below that also, but there's just not enough data below that. And if you were to look at the same sort of figures, but now looking at diastolic blood pressure, you see exactly the same thing. going down as low as 75 millimeters of mercury. So a continuous relationship between blood pressure and risk of vascular disease. The other good news, however, is that we can do something about it. The controlled trials of antihypertensive drugs have shown beyond all reasonable doubt that lowering blood pressure is a good thing to do. You see benefits right across the range of blood pressure, and the benefits are proportionally constant across the range. You see benefits in all age groups. You see benefits for reduction in not only diastolic blood pressure, which was the gold standard when I was a lad, but also systolic blood pressure. And you see benefits in low-risk people and in high-risk patients. The bigger the risk, the bigger the benefit, because the proportional benefits are always the same. So people with very high risk are the ones who are going to get very big benefit. So given that information, the guidelines from high blood pressure management should be quite simple. If you've got high blood pressure, it's a good idea to lower it. But if you look at guidelines, as I am forced to do, you often end up very confused. And the most recent guidelines that I've looked at are the European Society of Hypertension, the ESC, ESH guidelines, published last year. A huge document, multiple authors, and as you might expect when you have something like that, there's a lot of contradictory evidence within the guidelines. So I've tried my best to summarize some of the key points as far as these guidelines are concerned. So starting off with what would be the thresholds to initiate treatment. The message here is that for the bulk of people, anyone with a blood pressure of 140/90 or higher should be considered for treatment. However, in very old people, they suggest, and it is evidence-based, that a higher systolic level should be the threshold, at least 160 millimeters of mercury. In people who are at very high risk, however, they suggest lower thresholds, 130/85 at all age groups. The trouble with the guidelines is it's very difficult to work out what they mean by very high risk, other than to say people with established coronary artery disease or cardiovascular disease should be considered. But as you'll see from the left-hand column, they also suggest lower thresholds for similar people. So we're left in a little bit of difficulty, but the main message is anyone with a blood pressure of 140/90 or higher should be treated unless they're very elderly. And in people who you think are at very high risk, you should drop the thresholds even further. So that's where we should start. What should we aim for? Again, not entirely clear in the guidelines, but in general terms, they're suggesting 120 to 129 millimeters of mercury as a target systolic blood pressure for most people. A little bit higher in older people, 130 to 139, and also in people with chronic kidney disease, where there is some evidence that very tight control can reduce renal function. Again, in very high-risk individuals, you want to aim for very tight control, 120 to 129 over 70 to 79. So again, with the same caveats that I mentioned earlier, this would appear to be the targets. Again, rigorous control, particularly in people at very high risk, but perhaps a little bit less aggressive in people who are elderly or people with chronic kidney disease. When should we start treatment? Well, this depends on the risk of the individual. Everyone should be given lifestyle advice, and I'm not going to go into detail of what that should consist of. I'm sure you're all aware of the importance of reducing weight, reducing salt intake, etc. In people who are at low or moderate risk, then a period of lifestyle advice or lifestyle intervention is appropriate for, say, 3 to 6 months before you start treatment with drugs, only if lifestyle is ineffective. However, in higher risk individuals, very high risk individuals, especially those with coronary artery disease, renal disease, or have had an event such as a heart attack, or who have very high blood pressure, at least 160/100, then these people don't require intermediate drug treatment. And I'm sorry, there's an error on this slide, but immediate drug treatment. So whenever you diagnose high blood pressure in these very high-risk people, they should start treatment, and you should aim to achieve control of blood pressure within about 3 months. So that's what the guidelines tell us. Why do they tell us these things? Well, all blood pressure lowering drugs would appear to have a similar beneficial effect, and we know that lowering blood pressure is a good thing to do. So lowering blood pressure is an excellent idea. What drugs should we consider using? Well, the core drug treatment strategy, as defined by the ESC/ESH guidelines, is based on initial treatment with a renin-angiotensin system blocker, either an ACE inhibitor or an angiotensin receptor blocker, effective, well-tolerated drugs, together with either a calcium channel blocker or a diuretic. Now, why do they suggest this? Well, ACE inhibitors and ARBs are highly effective in people with a high renin form of high blood pressure, whereas calcium channel blockers or diuretics are highly effective in people with low renin hypertension. So by combining the two, you cover the options. The other important point to notice is that they are now suggesting that you start with 2 drugs in a single pill dual combination, except in old, frail people or people with marginally elevated blood pressure where the systolic pressure is less than 150 millimeters of mercury, and there you might reasonably consider starting with a single drug. The second step for most people is to combine a RAS blocker with a CCB and a diuretic, and to do it in a triple combination single pill. If that doesn't bring you to target, then you should consider adding in spironolactone or another drug, usually a diuretic, an additional diuretic, and now we're talking about 2 pills in combination. And at that stage, you should consider referral to a specialist. Although it doesn't tell you what the specialist is supposed to do, but nonetheless, that's what the guidelines tell us. Why is it then that there's this change in guidelines? Because we've all been brought up in the notion that you start low and go slow, monotherapy, building up treatment as we go along. Well, the reason for the change is that we're really not very good at controlling blood pressure. If you look at globally at control rates, you find that no matter where you look, that the number of people who reach target compared to the proportion that starts out is very small. So we do not control blood pressure as well as we should do. And the big clinical trials, which started with low-dose monotherapy and then built up treatment, have shown us that about a third of people will be normalized with a single drug, a third will require 2 drugs, and a third will require 3 or more drugs. So combinations are going to be required in at least 2/3 of the people that we come across. And always remember that adding in a new antihypertensive agent to an additional agent is far, far more effective than increasing from a low dose to a high dose. The extra blood pressure reduction from combining drugs is 5 times greater than that of doubling the dose. So that's another reason why combination therapy is sensible. Another thing that we've observed in the last few years, and this is a study that we did and published in 2011, where we looked at the renin inhibitor, aliskiren, and a calcium channel blocker, amlodipine, either as monotherapy or as combination therapy, and starting with 2 drugs was always better. The end result in terms of blood pressure control and side effects, always superior when the 2 drugs were combined. That was the Accelerate study. And we did a larger study, the British Hypertension Society did a larger study called the Pathway 1 study, and confirmed the results, finding that initial combination therapy, and now with an angiotensin receptor blocker together with a calcium channel blocker, initial combination much more effective than initial monotherapy, and surprisingly enough, tolerability was better if you started with 2 drugs. So we suggested that a change in practice was necessary, and I'm glad to say that seems to have now been incorporated into the recommendation. So now we start with combination therapy, and a single pill is going to result in much better compliance than if you give the two drugs individually. What about high-risk hypertension? Because that's what we're supposed to be talking about. Here the drug treatment strategies change a little bit, and they change to individualized therapy. People with coronary artery disease might well require a beta blocker for control of symptoms or a calcium channel blocker. So these drugs, a beta blocker is now considered to be a reasonable first-line therapy. Always remember, however, that regardless of what sort of patient you're dealing with, if you're combining a beta blocker and a calcium channel blocker, you must avoid using a non-dihydropyridine calcium channel blocker together with a beta blocker, because these two types of drugs can result in severe bradycardia and even asystole. So don't use verapamil or diltiazem with a beta blocker, but you can easily use a dihydropyridine type calcium channel blocker such as amlodipine. In chronic kidney disease, similar guidelines, giving you more flexibility in selecting the drugs that you incorporate. But again, initial treatment should be a dual combination, and step 2 should be a triple combination. And similar strategies in heart failure with reduced ejection fraction, again, individualizing treatment because these people will often require a diuretic and a beta blocker. And then adding in a mineralocorticoid receptor antagonist, such as spironolactone or eplerenone, as step 2, again, drugs which have been demonstrated to be beneficial in heart failure. And in atrial fibrillation, we are combining where rate control is going to be important. A beta blocker might well be involved in initial monotherapy, but remember that a non-dihydropyridine calcium channel blocker, while as effective as a beta blocker in controlling rate in atrial fibrillation, you should avoid combining the two. And if you have to add drugs together, then a beta blocker plus a dihydropyridine type calcium channel blocker is more appropriate. And then you add in other drugs as necessary. Why do we choose the particular drugs that we choose? Well, we've already discussed how renin-angiotensin system blockers are an appropriate first-line therapy, but should it be an ACE inhibitor or an ARB? Well, here is a very eminent cardiologist inspecting the data, and he sees the magic of ACE inhibitors. The cardiologists love ACE inhibitors, and they always think that ARBs are not quite as good, but that is not correct. Because if we look at a number of trials, of which the most important is the on-target trial, comparing an ARB-based therapy with an ACE inhibitor-based therapy, telmisartan against ramipril, you see that outcomes are exactly the same. There is no difference in outcomes. We're looking here at cumulative cardiovascular outcomes. So the ARB is not inferior to an ACE inhibitor in preventing cardiovascular events. It's just as good and is better tolerated. You do not get the cough that you see in about 15% of people who take an ACE inhibitor like ramipril, and you do not see the angioedema, a rare complication of an ACE inhibitor. Combining ACE inhibitors and ARB, however, is not a brilliant idea. No real advantages and many more side effects, particularly renal complications. So telmisartan in this study came out very well, and telmisartan is a pretty useful angiotensin receptor blocker. It has insurmountable blockade of the AT1 receptor, which means that it will work even in the presence of high angiotensin II circulating levels. High affinity and long duration of action gives it a long half-life. High transmembrane diffusion into tissues because it's lipophilic, so it will work in the tissues as well as in the circulation. A long half-life, as I've said. Negligible renal excretion, so safe in people with renal impairment, which is often the case in people with high cardiovascular risk, and some unique effects which may or may not add to the benefits of telmisartan. So an ARB like telmisartan is a very appropriate choice in your treatment strategy in high blood pressure for people with high risk or indeed people with uncomplicated hypertension. What about beta blockers? This is a slide which I use when I'm teaching the students and shows the key properties of ACE inhibitors, of beta blockers, selectivity, partial agonist activity, duration of action, and route of elimination. Ideally, we want a drug which is selective for the beta-1 receptor. We want one with a long duration of action. We want one which does not have partial agonist activity. And if possible, we would like one which is not eliminated by the kidneys. None of these drugs really completely satisfy these criteria, but metoprolol comes close. The only problem is it's got a slightly short duration of action, but since all the metoprolol preparations which are now available are sustained release preparations, that short duration of action is overcome. So metoprolol probably meets the requirements best of all: selective for the beta-1 receptor, no partial agonist activity, in a sustained release formulation, a long duration of action, and eliminated hepatically, so therefore easier to use in people who might have a renal impairment. What about diuretics? Which diuretics should we consider using? Well, here the evidence is difficult because there are no head-to-head comparisons of different thiazide and thiazide-like diuretics. A drug which is widely promoted in this context, indapamide, has only been studied in one trial against placebo in very elderly individuals. And it's important to note that the primary outcome, while going in the right direction, was not statistically significant. So not much evidence for that drug. And there's insufficient data for valid comparisons with other drugs. So we have to go back and look at historical evidence in trials with antihypertensive drugs, the evidence base for antihypertensive drugs against no treatment or against placebo. And there is a big evidence base, about 50,000 individuals studied in 17 unconfounded trials, first-line therapy, reserpine in 1, beta blockers in 4, and thiazide or thiazide-like diuretics in 14. Now that adds up to more than 17, but that's of course because in some of these trials more than one active agent was studied. The diuretics used were bendoflumethiazide, chlorthalidone, or hydrochlorothiazide, and although there is no high-quality evidence comparing the different diuretics, the data with chlorthalidone is the most convincing. So it's probably the diuretic that might be considered the one of choice. So now let's move on to diabetes, which is a very, very important risk factor or risk predictor, risk enhancer for coronary artery disease. It's also a risk factor for microvascular complications such as chronic kidney disease and retinopathy, as well as macrovascular disease, coronary artery disease, stroke, peripheral vascular disease. And I've added in this slide heart failure because we underestimate often the importance of diabetes in the etiology of heart failure. And just as many people with diabetes have heart failure as have coronary artery disease. So it's a very important complication of diabetes. So how are we going to go about treating the hypertensive patient with high-risk diabetes? Well, the guidelines, I've already shown you these data. Threshold 140/90 in younger people, 160/90 in older people, 130/85 if the individual is at particularly high risk. Targeting 120 to 129/70 to 79 in younger people, a bit less rigorous in older people, but except if they have very high risk. And again, dual combination therapy, moving on to triple combination therapy. And it's important to recognize that the drugs we use in diabetes are exactly the same as we would use in those without diabetes. I spent a lot of my career changing treatment because GPs felt that diuretics or maybe beta blockers were not a good idea in diabetes. And of course, diuretics in particular are almost essential to control blood pressure in diabetes. Once the patient has diabetes, if the drug worsens blood sugar control a little bit, that's not critical. So the same drugs that we might use in individuals who don't have diabetes. very strong evidence that tight control of blood pressure is a good idea. In the HOT study, we found, and I participated in that trial, we found that just a 2 or 3 millimeter difference in diastolic blood pressure reduced cardiovascular risk by 50%. Now, this was a sub-study, quite a small sub-study of a big trial, and therefore that information was not really incorporated into the guidelines. But the United Kingdom Prospective Diabetes Study and studies in chronic kidney disease have been incorporated. In chronic kidney disease, you see that there's a continuous relationship between blood pressure and the decline in glomerular filtration rate. So in other words, as you reduce blood pressure, you reduce the decline in GFR. So very, very important to control blood pressure rigorously in people who have renal impairment. It's always important to remember that diabetes is not just a disease of hyperglycemia. It really represents a clustering of cardiovascular risk factors: hyperglycemia, hypertension, obesity, and hyperlipidemia. So focusing our attention entirely on one of these risk factors is not going to be optimal. Certainly in the UK PDS study, if you look at all endpoints, both microvascular and myocardial infarction, you see that as you lower systolic blood pressure, then risk is reduced dramatically. Myocardial infarction in red, microvascular disease in yellow. So clearly controlling blood pressure is a good thing to do. And in fact, in that study, it was a better thing to do than controlling blood sugar. And this is often forgotten by diabetologists who focus a lot of attention on blood sugar control. But if you look at the data from these studies, such as UKPDS, you see that the benefits of tight blood pressure control were far more important than tight blood sugar control. However, we need to think of diabetes as a multifactorial problem. And the multifactorial intervention trial, published in the New England Journal of Medicine many years ago now, brought home this message very clearly. It's a small study comparing intensive and conventional interventions in people with type 2 diabetes with a follow-up of 7.8 years. And with this multifactorial approach, they could reduce cardiovascular morbidity and mortality and microvascular outcomes by about 50%. And you see that in this trial, those on intensive treatment were much more likely to achieve targets for hemoglobin A1C, cholesterol, triglycerides, systolic blood pressure, and diastolic blood pressure. So a clear message that if we want to optimize the reduction in cardiovascular risk in high-risk diabetic patients, we have to focus not just on blood pressure, not just on blood sugar, but all of the risk factors that cluster in people with diabetes. And this message has begun to come home to the diabetologists because they've observed increasing cardiovascular complications with some diabetic agents, such as rosiglitazone, and some of the newer drugs. Increased heart attacks, increased heart failure, perhaps due to this undue focus on glycemia. And the new guidelines now emphasize that for a new anti-diabetic agent, they have to provide evidence that it is safe and effective in reducing cardiovascular outcomes. The new drugs that we have, in general, control blood sugar. They also often reduce blood pressure. They often are associated with body weight reduction. Sometimes there's improvement in lipids, and there are also mechanisms that we don't entirely understand. So that's what an ideal new hypoglycemic agent would have. These are the properties. And there are a number of contenders. The DPP-4 inhibitors, the dipeptidase inhibitors, which prevent the breakdown of GLP-1 and therefore stimulate insulin release. The glucagon-like peptides, the GLP-1 agonists, stimulate insulin release. And then there's the sodium glucose cotransporter SGLT2 inhibitors, which prevent glucose reabsorption. There have been very positive results with the GLP-1 agonists and also more recently with the SGLT2 inhibitors. And I'm going to focus on the last class of drugs because I think a lot of cardiologists are not yet aware of the potential benefits of this class of drugs in high-risk diabetes. So what is the sodium glucose cotransporter? It's a low-affinity, high-capacity glucose transporter located in the proximal convoluted tubules in the kidneys, and essentially it controls glucose reabsorption from the urine. Because when the urine filters glucose, a lot of it is reabsorbed, and this is part of a mechanism of ancient origins where it was important for people to retain energy as much as possible when food supplies were not as available as they are nowadays. So these drugs reduce renal absorption of glucose, they increase urine glucose excretion, and they have other properties too. They facilitate insulin sensitivity and uptake of glucose into muscle cells, they decrease gluconeogenesis, and they improve first phase insulin release from beta cells in the pancreas. And the result of all of this is a reduction in blood sugar. So these drugs have potential. They have some side effects, as you might imagine, by increasing the amount of sugar in the urine. They facilitate infections, and they cause urinary frequency. But most people tolerate these drugs very well, and serious side effects are rare. But with one of these drugs, there was an increased risk of amputation in the large clinical trials, canagliflozin, evidence of increased amputation rate, which is a worry. A number of randomized control trials have now been done with these drugs, with 3 members of this class of drugs. And if we look at a meta-analysis of these drugs, their outcome studies looking at cardiovascular events, you see a highly significant reduction in all major cardiovascular events, a striking 31% reduction in heart failure admissions, and a reduction in all-cause mortality. I'm showing you the data there for hazard ratios at 95% confidence intervals, and provided the upper confidence interval is less than unity, that's a statistically significant effect. Real-life data with these drugs recently published in the BMJ, a big study, over 20,000 individuals studied in Scandinavia. We see the benefits that we talked about, we showed you in the previous slide, now comparing an SGLT2 inhibitors to DPP4 inhibitors, and you see a beneficial effect of the SGLT2 inhibitors. Significant benefits, either in an intention to treat analysis or sometimes in the on-treatment analysis for major cardiovascular events, heart failure. Then just look at the reduction in heart failure events and hospitalizations, reduced by by more than a third. Benefits from myocardial infarction, not statistically significant, nor for stroke, but cardiovascular mortality, significant on the on-treatment analysis, and all-cause mortality, highly statistically significant benefits. So these drugs, not only in outcome trials, but in real-life data, appear to be highly beneficial in cardiovascular protection. The first of these drugs that was studied in a cardiovascular outcome study was empagliflozin, the EMPA-REG outcome study, 7,000 patients with established cardiovascular disease, comparison with placebo, primary composite cardiovascular outcome, a 14% significant reduction, and again, this very big reduction in hospitalization for heart failure. So these drugs seem to do something special in terms of reducing heart failure. On the other results, there was no worsening of nephropathy. In fact, nephropathy was reduced. All-cause mortality also significantly reduced, and no safety signals. There was no risk of increased amputation with this drug compared to the data with the canvas study that I showed you earlier. And the findings were independent of baseline renal function. So what are the benefits that this drug provides in type 2 diabetes? Well, clearly it reduces blood sugar. It reduces hemoglobin A1C by about 0.7%. It reduces blood pressure by 2 or 3 millimeters of mercury. It reduces weight on average by around 2%, but a high proportion of people will have reductions of greater than 5%. And it improves cardiovascular and renal outcomes. Why does it do that? Well, I've already illustrated some of the potential beneficial effects, but remember, this drug, because it increases urinary sugar output, it acts as a diuretic, natriuretic, and reduces circulating blood volume, and this may explain why it has this particular beneficial effect in reducing hospitalizations for heart failure. The guidelines now suggest that drugs like empagliflozin are appropriate second-line treatments after metformin, particularly in those with established heart failure or cardiovascular disease. In fact, the most recent iterations of the guidelines suggest that these drugs could be used as first-line therapy. But at the moment, it's generally felt that you should treat your high-risk diabetic patients with lifestyle modification, then metformin, and if the hemoglobin A1C remains high, add in one of these drugs, empagliflozin. So that's really what I've got to say today. I apologize for my inability to pronounce the names of these difficult drugs very easily. My conclusions are that the recent guidelines strongly support rigorous management of high blood pressure, particularly in high-risk patients. The treatment is now guided by the risk in the individual. Another big change is the use of combination therapy and using combinations as part of single pill treatments. Treatment based on RAS blockers with other drugs added in as appropriately. And in diabetic hypertension, we should focus on multiple risk factor interventions, not just blood sugar control, not just blood pressure control, and novel agents such as the HDLT2 inhibitors are increasingly playing an important role in the management of these people. Thank you very much indeed for your attention. I don't know whether you can still hear me okay. I hope so. I see a couple of questions. What's the importance of 24-hour blood pressure control? Well, it's generally believed that 24-hour blood pressure control is very important in the management of all forms of high blood pressure. Anand. I seem to have managed to lose them. I don't know how I did that. You can hear me?
Yeah, you can.
All right, okay. Well, as I was saying earlier, the 24-hour blood pressure control is generally considered very important in the management of high blood pressure, but I have to say that the evidence base for this is not particularly strong. But there are some exciting new studies coming out looking at when we administer antihypertensive drugs, and we find that if drugs are administered at night rather than during, or in the evening rather than in the morning, then control of blood pressure throughout the 24 hours tends to be better, and there are suggestions that outcomes are also better. But the guidelines all support the notion that we should use drugs which provide 24-hour blood pressure control. But up to what GFR can we prescribe empagliflozin? Well, a GFR of less than 60, we should start thinking a little bit about the drugs that we use. We should use it with caution in such individuals, and below 30, you should not prescribe drugs of this class unless you are going to monitor the patient very, very carefully, or if you're a renal physician. How I diagnose resistant hypertension, how should it be treated? Resistant hypertension is conventionally considered to be individuals who, despite 3 drugs in combination, fail to achieve target blood pressure. I saw this all the time. This is a major problem. And very often it's because the patients don't take the tablets. We used to bring people, I would bring people into hospital for observation to give them their drugs under supervision, and very often I found that resistant hypertension disappeared. In patients with truly resistant hypertension, then you simply add drugs in combination, including a mineralocorticoid receptor antagonist, preferably spironolactone, because we now know that spironolactone is very effective as a fourth-line therapy in such individuals. And beyond that, you then have difficulties, because some people, it's very difficult to control, provided you are sure that they're taking their tablets. It can become very difficult. And there are, of course, as I'm sure you're well aware, there are other approaches that are now being talked about, but at the moment they are not really recommended unless under specialist supervision. What is the status of, I don't quite understand what that question is from Rahul Arora. Maybe he could try again there. Right, the next question I want to address is the one about what time we should give antihypertensive drugs. That is an area, as I said earlier, which is currently very interesting in that there have been a number of studies suggesting that the best time to give drugs is in the evening and not during the daytime. It's interesting that nighttime blood pressure, that is the blood pressure when people are at rest and asleep, is the strongest predictor of outcome. We very seldom measure this, of course, but studies many years ago showed that it was nighttime blood pressure which best predicted long-term outcomes. So there had been a move to give drugs in the evening, and we now know that if you give drugs in the evening, they will work highly effectively during the night and also during the next day. And there is some evidence suggesting that this might result in greater benefit. Of course, the problem is that some of the drugs that we might use are not particularly suitable to give in the evening, and I'm thinking there of diuretics. However, even diuretics might be acceptable because, in fact, the way that diuretics work is that for the first 7 to 10 days of repeated administration, there is indeed an increased diuresis. But after that, the body gets back into steady state. And when you think about it, that must be the case, because if you continue to excrete excessive urine and sodium forever with a diuretic, then you would die, and you don't die. So the body comes back into homeostasis. So it may well be that even diuretics could be given at night time. In anyone not taking insulin, what should be the treatment of type 2 diabetes? Well, I think that in type 2 diabetes, insulin, of course, is a drug that we sometimes have to use because they don't respond to other drugs, but I would reserve insulin for patients who are not responding well to the drugs which I've mentioned. Lifestyle modification followed by metformin, followed by one of the newer classes of drugs, perhaps a SGLT2 antagonist. If you're still having problems, then the patient should be seen by a diabetologist and insulin might be needed. I don't understand the next question. I don't understand what IBBB is. Then the next question that I can address is whether spironolactone is better than eplerenone in treating resistant hypertension. And the answer to that is yes, it is. I did my PhD, my MD thesis on the aldosterone antagonists, and particularly on spironolactone. I spent a lot of time working with the mineralocorticoid antagonist. Eplerenone is a drug which is, on weight-for-weight basis, much less effective than spironolactone. The problem with spironolactone, of course, is that at higher doses, there's a high frequency of gynecomastia. With eplerenone, you don't see that, but I wonder whether if you increased the doses of eplerenone until you had equivalent doses to spironolactone, you might begin to see the same problem. So my advice is to use spironolactone, and at doses of less than 100 milligrams a day, 25, 50 milligrams, the frequency of gynecomastia in men is very low. If you run into gynecomastia, one possible approach is to use a low dose of spironolactone together with a low dose of eplerenone to get more anti-menarchod effect without gynecomastia. But otherwise, I think spironolactone has it. Have we any other questions? Vildagliptin. Yes, I have done some work with this agent and published a large review of literature with this drug. And indeed, in heart failure patients, this drug is not harmful. It will not produce the same sort of beneficial effects that you see with the SGLT2 antagonists, but it shouldn't cause any particular problem. So it can be used, but as with all of these drugs, you must monitor the patient very carefully. If we have any further questions, I'm still here, but we seem to have run out of questions. Are we still? We had a lot of questions came through, but some of them I didn't really understand. That's it. Okay. So if there are no further questions, thank you very much indeed for your attention. It's been a pleasure speaking to you, and I hope it's been helpful for you. All the best. Bye.